Okay guys, I just wanted to do a quick little additional PowerPoint with this module before we get into the extra fetal assessment, talking about placenta, fluid, cervix, all of those other structures, kind of just putting together what a basic general protocol is going to look like in terms of second and third trimester OB, and what some of the differences are between an anatomy scan versus a growth scan versus a BPP. So we're going to be talking about some of the different types of exams that you could do depending on the patient's clinical reason. So our standard anatomy scan, this is something that every pregnant woman is going to be required to have. This is looking at all of the different organs and structures of the baby just to make sure that that development has happened properly and is going to continue to happen properly. We're typically doing anatomy scans anywhere between 18 to 24 weeks. The sweet spot's going to be right at 20 weeks. We can see everything as well as possible without worrying about all of that further ossification from all of the bones that are developing as well. So when we're doing an anatomy scan, we need to take pictures of some of those extrafetal organs and structures. So we need to be looking at the cervix particularly. We need to make sure that that cervix is closed. We're going to learn all about that in our next PowerPoint in this module. We also are looking at our adnexas. We're looking for those ovaries, making sure that they have nice blood flow to them. Sometimes as our pregnancy grows, it can compress the vessels going into the ovaries and it can cause a torsion. We also want to be looking at our placenta, at our umbilical cord, at the fluid. When we're looking at the fluid, we're actually taking measurements of the different pockets, kind of similar like to an ascites check, but we call this our AFI, our amniotic fluid index. We're going to talk all about that in our next PowerPoint as well. We're also documenting the fetal presentation. So is the baby head up, head down, head to the side, right? They're going to be cephalic, breech, transverse. And then we're going to start to look at some of the specifics of that baby. So we're going to be starting mainly in the brain if you can. We like to kind of get those pictures confirmed right at the beginning of the exam because they can be kind of hard to take depending on how active the baby is and how they're positioned. So when we're looking at the head, we know that we need those four structures in order to do a BPD and a head circumference. That BPD is going to be measuring from the outer anterior bone to the inner posterior bone of that head that is going across our screen. Our head circumference is going to be our circular ellipse measurement, where we are measuring outer to outer with our calipers. We are going to try practicing using the ellipse measurements on our phantom. It's not the best phantom. It's really not useful other than to practice those knobology controls and measurements. When we're also looking at the head, we are looking at our lateral ventricles. We're doing that AP measurement of that lateral ventricle. We're also looking at the posterior fossa, which we know has our cerebellum, our cisterna magna, and our nuchal fold. We're going to be doing measurements of all three of those in that one picture as well. We're looking at our fetal spine. We're doing sag and transverse pictures. We're going from our cervical spine, about our neck, all the way down to the sacrum. So we're doing cervical, thoracic, lumbar, and sacrum, both in sag and transverse. In sag in particular, it's important for us to show the nice skin border along that baby's back to make sure that there are no defects in that soft tissue. In transverse, we're looking to see those three pronounced ossification centers. We're then going to be looking at the baby's rest of their face. So we're going to be looking at their fetal profile. We're looking for that nasal bone in relationship to the frontal bone or their forehead. We're also doing a nose-lips picture. Now, a lot of anatomy scans do not require you to do a palate picture, but you will see some techs perform that if they can. Nose-lips is absolutely required, and that's going to show us the start or the severity of a cleft lip in that baby. We're also going to be looking at the long bones, particularly the femur length. So we need to be doing a femur length measurement. We know that that femur needs to be going horizontally across our screen. We're going to be measuring our anterior leg, and we want to make sure that we are measuring from end to end of that femur. And sometimes those cartilage centers or those epiphyseal centers are going to look a little bit like they're part of the femur bone, but they're actually not. So we're going to kind of go over that a little bit as well. We then need to be looking at the hands, the feet, the fingers, the toes, all of those extremities, making sure that we can document both the right and left hand, right and left foot, and that each hand and each foot has 5 digits. We also need to be looking at the forearms of the baby and also the calves of the baby. That's not on here for some reason, that got cut off. When we're looking at the forearms of the baby, we want to see the radius and the ulna parallel to each other. So we want to see them nice and elongated, proving that both bones are there in both arms. Same thing with our calf bones. We want to be showing the tibia and the fibula elongated, and we also want to show the relationship of the tib-fib with the foot. If we have an abnormal relationship of the tib-fib and the foot, an abnormal angulation, that's when we're going to be questioning club foot. So we want to make sure that we're getting those beautiful pictures of those paired bones in both the forearms and the calves. We also want to make sure that we can document our diaphragm and sagittal. We want to make sure that in sag we are showing the heart above the diaphragm in the thoracic cavity and the stomach below the diaphragm in the abdominal cavity. We're then starting to look into our belly, so we're going to be doing another ellipse rounded measurement of our abdominal circumference. We want to make sure we are including the soft tissue of the baby's belly. Now, babies' bellies are going to be very squishy, so sometimes that measurement can look a little bit oblong or a little bit oval instead of perfectly round. And we just want to try our best to get it as round as possible for our ellipse measurement. Sometimes we can be pushing too hard on the baby and we could actually be squishing their belly, making it look a little bit more like jelly bean shape rather than nice and round. So just be aware of your pressure when you're looking at your abdominal circumference. When you are looking for your abdominal circumference, you also want to make sure you're getting transverse spine, stomach, and umbilical vein. Those are going to be very important in terms of your landmarks. We don't want to see any kidneys in the abdominal circumference measurement. That's going to tell us that we are a little bit too low. So we want to document our kidneys separately from our abdominal circumference. We're going to do so in transverse. We're going to see them on both sides of our transverse spine, nice and beautiful and pronounced. We sometimes like to change the tint on our machine to make those kidneys pop a little bit more. It changes the contrast of them. And then we're taking a picture of our bladder. So we want to make sure that that baby's bladder is nice and full. Sometimes if it looks way too big, we want to wait for it to to empty a little bit, and then we'll take another picture. Or if we don't see the bladder at all, we know that we need to wait a little bit to see if it will fill. Maybe we just missed it. It had just emptied and we just missed it. We're then going to be looking at the placenta. We're going to be seeing where that placenta is positioned and the relationship of that placenta with the baby. We know that our umbilical cord is going to insert from the placenta into the baby's umbilicus. So we want to see that cord insertion into the fetus and also into the placenta. Our umbilical cord should represent 3 vessels. So we should be seeing the 2 umbilical arteries and the 1 umbilical vein in that umbilical cord. And then as for our fetal heart, now remember, we are not going to be doing a full in-depth evaluation of the baby's heart. If we see something abnormal with the basic views, they're going to be sent for a fetal echo. When we are looking for our heart, we need to make sure that it is pointing, the apex of that heart is pointing up. That's going to be the best way that we can get the 4-chamber view. We want to make sure that our chambers are looking proportional to each other. We know our ventricles are going to be triangular in shape, and then we know our atria are going to be a little bit more rounded in shape. We are showing that 4-chamber heart nice and equal, and then we're also doing M mode for fetal heart rate. In addition to our 4 chambers, we are going to be turning on the right ventricle and turning on the left ventricle to evaluate those outflow tracts. So we want to be showing the pulmonary artery and the aorta coming out of those ventricles to make sure that that baby has proper circulation elsewhere to the body. Now, of course, if we see anything abnormal with any of those standard views, we're going to evaluate further by sending them to a fetal echo. And then we are also documenting gender just for purposes of genetically linked disorders and conditions. Okay, so we oftentimes do growth scans or limited OB scans to make sure that the development of that baby is happening beyond that anatomy scan. So for whatever reason, if that baby has been kind of measuring too small, or if that baby has been measuring too big, or we're kind of worried about that baby, we can do kind of like a checkup. So typically these are going to be patients who have already had their anatomy scans done, and now we just need to make sure that the major things are looking okay and that the measurements are lining up with how far along that baby should be. So when we're doing a growth or limited OB, these are kind of the standard pictures that you want to be taking and the standard structures that you want to be evaluating. So of course, we're always going to be doing our cervix. That's very important, making sure that it's nice and elongated and closed. We're looking at our placenta, make sure it's still nice and attached to that myometrial tissue of the mom. We're also looking at our fluid. That's very important as we get later on in pregnancy. If the baby doesn't have enough fluid or has too much fluid, that's going to be a complication. We're then doing our measurements. So we're doing our head circumference, our BPD, our abdominal circumference, our femur length, to make sure that all of those measurements should line up with how far along that baby is. We're also looking at our kidneys and bladder, making sure that those are functioning. When we have abnormal fluid levels, whether it be too high or too low, we always want to check the kidneys, because the kidneys are going to be that driving factor of how much amniotic fluid is produced. So the baby's kidneys are actually going to be producing that fluid. So if we don't have enough fluid, well, then we got to question what's going on with the kidneys. Why aren't they working as well as they should? We also are still going to be documenting our bladder, and then of course our 4-chamber heart and fetal heart rate. We're not doing outflow tracks for any sort of growth or limited OB. Next, we also have a BPP. This stands for a biophysical profile. This is something that, again, we are doing in addition to anatomy scans. This is where we're a little bit more concerned with the function of the baby. So in growth and a limited, we're kind of concerned with how big or how small that baby is, so how much they're growing or how little they're growing. A BPB is, we're kind of like concerned about why that baby maybe isn't moving, or why that baby isn't breathing, why we have decreased fetal movement. So this is something that we kind of get a little bit more concerned with, and depending on how the baby does on this exam, we could deliver early to get that baby out. So this is usually going to be done, so these ultrasound evaluations are going to be done with a non-stress test. So basically a non-stress test is where they put these little electrodes on your belly and they monitor the fetal heart. So it's kind of something like you'll go for your ultrasound and then you'll go for your non-stress test, or vice versa. Like you'll go for your stress test, non-stress test, and then you'll go for your ultrasound evaluation of the other categories. So when we're looking on the ultrasound, we need to be observing specific things. We need to be observing the baby breathing. We need to make sure that the baby is moving their head. We need to also make sure that the baby is suckling or swallowing, and we're looking for the fetal tone. Now, fetal tone is when that baby is actively either flexing their extremities or extending their extremities. So is the baby kind of kicking out and stretching their legs? Are they stretching their arms? Are they curling their arms, curling their legs? If so, that's going to be a good sign. So when we see these things, we give 2 points to each of those categories. So if the baby moves, 2 points. If they have active flexion or extension, 2 points. If they demonstrate examples of breathing, 2 points. If we have appropriate AFI levels, another 2 points. Now that suckling and that swallowing, that's going to kind of contribute to that AFI. So if the baby is swallowing the fluid, the kidneys can filter it, process it, output more amniotic fluid. So we need to make sure that that fluid levels are indicating that the baby is actually suckling, swallowing, and the kidneys are functioning properly. So now, depending on how the baby does during this evaluation, we are going to kind of take different plans of action. So a biophysical profile is basically a graded system to help us determine asphyxia. Now, asphyxia is when we just have the inability to basically breathe. So, kind of like anaphylactic shock, where you just can't breathe and everything kind of shuts down following that. This is when we can kind of see that in those babies. So asphyxia is this general term talking about, for some reason, the inability to breathe easily. So when we see each of those categories on ultrasound and with the stress test, we give 2 points. If we don't see it, we give it 0 points. So basically, you want to get as many points as possible, because that's going to say to you, like, yeah, this baby's okay. It's doing all the basic functions that they should at this point. So if we see it, they get 2 points. If we don't see it, they get 0 points. There's no 1 point assigned for anything. Now, fetal breathing, we want to be demonstrating that or observing that for at least 30 seconds. We don't want to just see one breath and then that's it. We just say, oh yeah, that they're breathing. No, we need to watch that they're like consistently breathing in a pretty steady pattern. Now that fetal tone, we want to see limb extension or flexion. Typically we want to see both. Amniotic fluid, we want to have a nice normal level of that fluid. We'll talk about our AFI characteristics in our next PowerPoint. And then movement, we don't want to just see one little flicker. of that baby moving. We want to see at least 3 different episodes of that baby moving or limb movement. And then our non-stress test, we should see at least 2 episodes of acceleration in that fetal heart rate of greater than 15 beats per minute for 15 seconds. So what does that mean? Like, babies' heart rates are very sensitive to when they're moving in utero. So if your baby kind of kicks you, that fetal heart rate is going to accelerate pretty significantly above that 15 beats per minute. And then sometimes it takes a while for that heart rate to go back down. So when you're having one of these stress tests, you can actually hear the baby's heartbeat, and then you'll feel a movement, and then all of a sudden you hear that heartbeat going boom, 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 like way faster than it was before you felt that movement. And then after, a few seconds, 15, 30 seconds, you're going to kind of hear that heartbeat go back down to normal. And then they're going to move again, and then it's going to go all the way back up. So that's normal, and we want to see that in the baby. We want to see those fetal heart accelerations after that baby has moved, or really kind of just for any particular reason, but it always is going to happen after that baby moves of some sort. Here is our scoring. Like we said, the more points, the better. So if we got 10, that means we saw all of those parameters. There's no evidence of asphyxia. Our management is going to be conservative. So we're basically going to kind of just like keep an eye on this mom for whatever reason that we were already keeping an eye on her for, and we're not really super concerned. If we missed one of the parameters, we're going to say, there's no acute asphyxia going on. So like there could be intermittent asphyxia where that baby is struggling to breathe, but we didn't pick it up on this evaluation. So we're going to have this mom come back for serial testing. So she's probably going to have a BPP done probably about twice a week. Now, if we have a score of 6, now we didn't see 2 parameters. This means that this baby is struggling, most likely struggling. If that baby is greater than 32 weeks old, we're going to deliver that baby. We're going to get that baby out because for some reason they're struggling in there. So we're going to get them out, and we are going to intervene medically once they've been delivered. If we only have 4, same thing. We got to get that baby out, but now we don't wait as long. So if the baby is greater than 26 weeks, same thing if we get a score of 2. If that baby is greater than 26 weeks, we got to get them out, because this baby is really struggling. They're not moving, they're not breathing, they're not swallowing, they're not, representing any of these parameters that we need to be seeing. And then same thing with a score of 0. This means that asphyxia is most definitely happening. Again, we're going to try to deliver, but hopefully it's not too late at that time. If the baby is not representing any sort of movement, breathing, swallowing, anything, that's when we kind of run into the world of a stillborn baby. So very concerning, and we need to make sure that if we are responsible for performing BPPs, that we are doing our due diligence and we are making sure that we are truly observing those parameters as well as possible. Next, we have our fetal dating and positioning. So the fetal dating, you guys know all of this. We've said this about 3 times now. Our Nagel's rule, same thing here, is just kind of like a recap of all of our measurements that we would be performing, just kind of reiterating what is necessary for each of those measurements. Our cephalic index, like we said, this is going to determine that baby's head shape. Our system is typically going to calculate that for us when we do our BPD and our OFD. This is going to be something that we come back to when we're talking about fetal abnormalities that are affecting the cranium. Our femur length, same thing kind of going on here. Now with our femur length, we know it's going to be very indicative of gestational age, so it's going to be pretty accurate. And our femur length is going to be 2 standard deviations below the mean in abnormal cases. So when we're looking at a baby that has some sort of skeletal development abnormality, we call those skeletal dysplasias. Our femur length is going to be significantly smaller than that baby's gestational age. So say you come in for a growth scan and your baby's a lot smaller than they want you to be measuring. You're supposed to be 32 weeks. The femur length is only going to be measuring like 25 weeks. We're going to be questioning some sort of skeletal dysplasia for that baby. This picture is a great representation of why we don't want to be imaging the epiphysis of the long bone. So we don't want to include like this region here when we're measuring. We're only measuring from here to here. And sometimes that can be pretty tricky. So our epiphysis here, kind of just reiterating why we don't want to include that in them. These are going to be pretty variable depending on the baby, depending on the baby's age, and they can be helpful in terms of indicating gestational age depending on what type of epiphyseal center you are seeing where, but we are not commonly performing this. We don't rely on this to help us figure out the baby's gestational age. There are other measurements that we can do to do that, but just for your board's purposes, we can have the epiphyseal center at our distal femur. If we see that, we know that baby is at least 32 weeks. If we see the proximal tibial, so now at the top of our tibia, if we see that epiphyseal center, that baby is at least 35 weeks. And then if we see the proximal humeral epiphyseal center, that baby is going to be at least 38 weeks. Again, we don't really care about it, but it is something that some places can use to help indicate gestational age. Now, if I'm 38 weeks pregnant, I kind of like don't care about knowing the specifics because you could have that baby at any second at that time. So chances are we're not really ever going to be performing those. Now, we do have some other parameters, other types of measurements that you could do depending on the indication, depending on the patient, depending on the protocol of where you work. We can measure the clavicle, we can measure the foot, we can measure the other long bones. So we could do humerus, radius, ulna, tib, fib. Now, sometimes we actually do measure our radius. That's going to be an indication of some congenital abnormalities. Of course, if we're looking at any indications of club foot, we might want to take a further evaluation of the tib fib just to kind of see like how severe that club foot is with the foot in relationship to the calf. We also can do our binocular distance, our outer orbital distance. This is going to be helpful with cases of IUGR. And then sometimes we can measure our transcerebellar distance. This is also helpful in cases of IUGR. Now, our fetal weight. This is so unreliable in our profession, and this is something that a lot of people who don't work in healthcare tend to get mad at ultrasound for. For some reason, a lot of OB physicians rely on ultrasound for fetal weight, and they kind of tell their patient what that estimated fetal weight is based off of their ultrasound measurements, and then they push the patient to get C-sections. Because they are saying, oh, on your ultrasound, the estimated fetal weight, your baby is already 9 pounds and you still have 4 weeks to go. When it's so highly inaccurate. So it continues to be a controversy in the OB world. It continues to be a controversy in the OB ultrasound world. Radiologists usually do not even report on the estimated fetal weight because of that. But it is something that our systems calculate based off of all of the measurements that we put in the calc package. Now, we do expect to see significant changes in that baby's weight in the 3rd trimester. And after about 36 weeks, we expect the baby to gain at least 1 pound. So we do expect to see that kind of rapid growth of that baby really towards the end of pregnancy, which as a woman sounds really fun because you've already gained a ton of weight and now you're going to continue to gain a ton of weight, and then you have no room for any of this. So everything becomes pretty uncomfortable for you as the patient. Sometimes if we have a physician who is relying on ultrasounds for fetal weight for whatever reason, we are going to be doing serial ultrasounds for that. So probably about once a week, we'll be doing some sort of growth scan just to see what that fetal weight is doing. Now, there are some reasons why we should be doing serial growth exams for questions of estimated fetal weight, and those are really going to be in cases of gestational diabetes or diabetes mellitus. So when you have a patient who has diabetes, whether it be type 2 diabetes or whether it be gestational diabetes, those babies have the risk of being very, very large babies. They can become they can have macrosomia. So they have basically just this monsterly large baby, no matter what they do. And that's because the placenta can't process the sugar in the mom's system. So it just sends it all to the baby and the baby just gets really, really big. Now, we want to monitor those patients because if that baby truly is measuring 10, 11 pounds at the time of delivery, chances of running into vaginal delivery complications is likely. So those moms are going to be pushed to getting a C-section to help deliver that massively large baby. Now, if you're a patient, you don't have any type of diabetes, that baby might be measuring a little bit bigger than the average person, but you're not falling into that macrosomia category of this like gigantic baby, then we shouldn't be doing this, because we can inappropriately or inaccurately make that baby look like it's 10, 11 pounds, when in reality that baby's only 8 pounds and very easily could have a vaginal birth. So something that's highly controversial, but we do need to be aware of why we might sometimes need to do it. Next, we're going to determine fetal positioning. Now, if you were in my little session at the beginning of the summer, you came in and you saw a bunch of circles on the wall and it says, you know, at 3 o'clock, head right down to the bar. And you're like, what are you talking about? Like, I'm not even 21. Why are we saying this? So this is going to be the kind of acronym, I guess you could say. It's not really an acronym, but the thing to remember how to determine fetal positioning based off of an image, right? And based off of what your transducer is doing. Fetal positioning: baby's head up, baby's head down, baby's head is to the mom's right or the mom's left. Now, first we need to determine, is the baby head up or head down, or are they sitting side to side? And there are 2 different ways that we can do that, and then we can further specify what category of that position that baby is in. So if you have a transverse image of the baby's abdomen and you are in a sagittal transducer position, so the goal with this is you always want transverse baby abdomen. Now, how do you get transverse baby abdomen? Is your probe sag or is your probe transverse? That's going to indicate what category we're falling into. So if you have transverse picture of the baby and your transducer is in transverse, then that means your baby is either head up or head down, cephalic or breech. Now, when you're looking at that transverse picture of the baby with your transducer in transverse, you want to always say that my spine is 12 o'clock. So your spine is always 12 o'clock. Now you want to say, where is my stomach in relationship to this spine? If you're looking at your spine, it's at 12 o'clock, and then you see your stomach clockwise at 3 o'clock, that baby is cephalic. If you don't see that stomach until you get all the way clockwise 9 o'clock, then that baby is breech. Now we have pictures of this. We'll go over that in a second. So that's how we determine if the baby is head up or head down. If your transverse baby belly is obtained by your transducer in a transverse position. Now, if your transverse baby belly is obtained with your transducer in a sagittal position, that means your baby is lying transversely across the mom's belly. Baby's lying side to side. Now we say, okay, well, is the baby's head on the mom's left side or is the baby's head on the mom's right side? So we have our transverse belly. Our spine is still 12 o'clock. Now, if our stomach is at 3 o'clock, baby's head's to the mom's right side. And if our stomach is at 9 o'clock, baby's head is towards the mom's left side. So at 3 o'clock, head right or down to the bar. Okay, so if your stomach is at 3 o'clock, the baby's head is either going to be to the right or down. Okay, depending on your transducer position. So on your boards, you are going to get questions that look similar to this. And they're going to tell you with a transverse transducer orientation or with a sagittal transducer orientation, this image was obtained. Now you have to say, okay, I know I always want to find my transverse baby belly, and that's what all of these pictures are showing you. How did I get this transverse baby belly? That's step 1. Was it sag or was it transverse? If I got it from a transverse transducer, I know my baby is either head up or head down. If I got it from a sag transducer position, I know my baby's head is either towards the right or to the left. So if we look at this top picture here, now we're going to pretend that this isn't here. This is going to be our baby belly, right? We said that our spine is always 12 o'clock. Here's our spine. And then our stomach we want to find where it is in relationship. So here, oh, wait, we found our stomach. So that's at 3 o'clock. So here's 12, and here's 3. Here would be 6, and here would be 9. Okay? Now, these pictures don't tell us how we got the picture, but your registry will tell you. So if this picture was taken with a transverse transducer, let's say this, we're going to just take all that out and make up our own scenarios for these. We'll say the second one was a Sag, and then we'll say another transverse and Sag. Okay, so our top one, we had transverse transducer position. So we know that this is either going to be cephalic or breech. Cephalic means head down. So we have our stomach at 3 o'clock, head right down to the bar. So this means that the baby's head is down. This means that this baby is cephalic. Okay. Now our second picture, our transducer is in Sag. So we're not questioning are they cephalic or breech. We're questioning is their head to the right or head to the left. So we have our transverse belly, we have our spine here. Here's 12 o'clock, 3 o'clock, 6, 9. Our stomach is at 3 o'clock, right? So this means that at 3 o'clock, head right down to the bar. This means that the baby is going to be towards the mom's right. Now this bottom one, transverse transducer, so cephalic or breech, we have 12 o'clock spine, we have 3 o'clock, 6, 9. Oh, our stomach is at 9, right? So now it's not 3 o'clock, head right down to the bar. It's 9 o'clock. So now it's going to be the opposite of that. So we know that it's either going to be cephalic or breech. The opposite of our little saying, instead of head right down to the bar, this is going to be head up. So this means that the baby is breech. Our bottom picture, we have our spine here. We have, that's our 12. Here's our 3. Here's our 6. Here's our 9. Oh, and our stomach is still at 9 o'clock. So it's going to be opposite of our little saying. So we're in a sagittal position. So we know our head is either going to be to the right or to the left. And at 3 o'clock, our stomach's not at 3, so we can't head right. So we're going to head left. That says left. So we'll go over some of this again if we want. If you guys feel like you need more clarification in purpose, we can go over, in person, not purpose. We can go over that a little bit more, but it is pretty self-explanatory. It is pretty straightforward. If you know how your transducer is being held, you can evaluate your transverse baby belly to figure out what that positioning is. So your boards love to ask you questions like this where they'll give you a picture very similar and you have to determine that fetal presentation.